I slightly feel like I'm here by accident almost, which probably has got Leslie Kirkpatrick as the main person to blame.
Actually, just blame Leslie for everything, shall we?
Yeah, why not? Why not? I'm going to talk about the role of surgery for metastatic ocular melanoma. I'm a consultant in liver and pancreatic surgery in Southampton, and I've got a big interest in minimally invasive surgery. You usually know when I haven't got that much to say about the specific topic when I start bringing out the slide of Prometheus. He was the lord of the Titans who stole some fire from Zeus, I think it was, and got into big trouble. As a result, vultures ripped his liver out on a daily basis on top of a mountain. That was what he was cursed to his fate. But it highlights the fact that the liver regenerates, and so every day he could come back for more. And it's one of the key things with liver surgery is that you can actually remove a very large amount of liver, 3/4 of a healthy liver, and it will regenerate, it will grow back relatively quickly within weeks or months, and it's ready for more. There's a few other names here. Pringle was one of the very earliest liver surgeons. You've heard some disappointing results from trials and studies reported. He reported about 100 years ago his experience of battlefield injuries with the liver, and he discovered that by clamping the blood flow going into the liver, he could keep the patients alive for an extra 30 minutes, but still none of them survived. That was really the closest we came in advance in liver surgery until the 1950s, when a French team started to look at segmental liver anatomy and actually look at identifying the anatomy inside the liver and trying to work out a way of controlling the blood supply and blood flow through various bits. Merv Rees is a surgeon still practicing today in Basingstoke in his 60s, and he's really been the godfather of UK liver surgery, and he's a man who's helped to change the face of liver surgery, really. So 1951 was the first successful major anatomic liver resection. A guy in Paris who took out about 55% of the liver, as the right side's a bit bigger than the left. But still, 35 years on from that, when I was training, there were series being published from large institutions where they'd report 20-odd patients, and a third of them would die related to their surgery, which really makes liver surgery pretty unacceptable if that's the kind of results that you're going to be putting out. But these days we can do rather better than that. Merv Rees published his first 1,000 cases about 5 years ago with a 1.6 mortality percent. In Southampton we've just topped 300 keyhole liver resections that we've done, which is about half of our liver work is done as a keyhole procedure, and we've had 2 deaths out of 300 patients over the last 8 years. So liver surgery has actually reached a point where it's worth considering in actually a wider range of conditions. What's changed over these years? Well, there's low venous pressure anaesthetics. So the liver's a big sponge. If you think of a bit of liver you get from the shops, not that people eat liver that much these days, I've certainly stopped. But except strangely enough at liver surgery conferences, where it's always on the menu at the conference dinner. I don't know why. Anyway, so the liver's like a sponge, and the bit of sponge that you get from the shop is empty. It's collapsed down, it's got no blood in it. If we can make the sponge empty, then it's safe to operate on, and it's safe to do many other procedures too. So we alter the hemodynamics of the patient, the blood flow through the liver and around their body, to make the liver surgery safe. We've got better kit to allow us to do all of that. We understand our way around the liver. We've got a route map inside the liver these days. And liver surgery is all done in high volume centres. And I think for things that aren't done frequently and for conditions that are rare, the conditions need to be managed by people who manage them a lot, because the more you do things, the better you get at it. And there's been developments in critical care, high dependency units, so that perioperatively, as soon as the patient comes off the table, however sick the surgeons made them, we bring them through. And then we also, with keyhole surgery, minimally invasive techniques, and the way we try and get people going very quickly, around about 1/4 of our liver surgery patients go home within 2 days, and half of them go home within 5 days. Keyhole liver surgery, I'm just going to talk a little bit about that before I actually go on to specifics of ocular melanoma. As I say, we've done around about 300 cases in Southampton. It's gone from being our first one in 2003 to now where we're doing probably about 55% laparoscopically, which is a fairly unusual situation. Worldwide, there were only 2,900 cases reported, so probably 2 or 3 times that number that have really been done. This is a video, if it starts, of somebody having the same sort of operation that Laurent Jacob did in Paris in 1951, but done as a keyhole procedure. Virtually no bleeding because we've controlled the sponge. Oh, didn't go for very long, did it? Give it another go. It wants to go. Yeah. So that's dissecting down onto the inferior vena cava, which is the major blood vessel in the lower half of the body, draining blood up to the heart. And you can manage to do some really quite major things as a keyhole procedure. Going back a few years, when we started out, we really only operated on things on the corners of the liver that were easy to get at. These days, we can approach most of the liver in a keyhole fashion. And as I said, you can turn around quite quickly and go home quite quickly after you've had keyhole surgery. So this is our total length of stay in blue. This is for our first 100 patients, and I'll be honest, we've pushed things quite harder, a lot harder these days. But still, the majority of patients are getting home within 2 or 3 days. If you look at the liver resection data across the UK, I'm afraid that little one line there is the number of patients having a liver resection for ocular melanoma. So you have to put it in perspective. If there's 2,000 liver resections a year in the UK, there's probably fewer than 5 done each year for ocular melanoma. So at the moment, there's not a lot of that goes on. Southampton in our institute, partly because we have a lot of links with, very broad links with the oncology department, and also because I think with keyhole liver surgery, where we're able to offer operations that are low impact, we're actually taking on lots of other cancer groups that traditionally actually only make up a fraction of normal liver surgery. And within that, there's a little bit of ocular melanoma. Now that's obviously, again, quite biased as a case group because people find us through the Ocular Melanoma Forum and so on. But nonetheless, I think there is potential for that to develop. The biggest group that you saw on that previous slide is the colorectal liver cancers. So they're people who have a bowel cancer that's spread to the liver. And I'll just briefly use some of their data to illustrate the relative safety of doing keyhole liver surgery and give an idea of what liver surgery can do for you in another condition. So this is some of our results from Southampton showing that for colorectal secondaries in the liver, over the first few years of our laparoscopic liver surgery program, we were getting up to doing around about 40–50% of the bowel cancer secondaries as a keyhole procedure. I'm doing more of them now. If you look at the two groups, they're roughly comparable in terms of age, sex. The operations take a bit longer if you do a keyhole, but you lose a bit less blood on average. But the length of stay is dramatically different. And that really does make a big difference if you're looking at doing this as part of a program involving other treatments. Because if you're turning around more rapidly, then you've had a smaller physical insult, a smaller immune system insult, and you may be better placed to then go on to secondary treatments. This is a statement on international consensus conference about keyhole liver surgery, which basically said that it's comparable to open liver resection, so we're not completely off the wall by doing it. This is right hepatectomy, which is the kind of big index operation, splitting the liver in two, taking out the slightly larger right side. And again, this is for a small cohort of patients that we matched and basically randomized into two groups. And again, it's showing that essentially you at least get, these are the demographics on the patients. But looking at the outcomes, yes, it takes longer, but the stay, again, dramatically different between the two groups. Not much difference between blood loss. and in terms of complications, again, nothing statistically significant. These results, you can't really compare these particularly. This is another different group. But basically we're showing that the keyhole liver surgical patients certainly do no worse than the open colorectal liver surgery patients. Again, there's case selection bias in that, so we can't really directly compare. This is the first open liver resection that I did for OM. This is a gentleman who presented with this 23 years after he'd had his primary removed. And that was the tumour that we resected. Sometimes just because something looks difficult doesn't mean you can't do it. And if you look at somebody who's got biologically favourable disease, sometimes it can be worth pushing the boat out. And he got 4 and a bit years from that procedure. Really what we're looking for is something called R0 resection. And R0 or R0 is, means that you've removed all of the tumour that you can see, and when the microscope is applied to it by the pathologist, the margins are clear as well by at least 1 millimetre. So that's our kind of gold standard, is can we remove all visible tumour? Because the evidence is that you will get up to around 2 years of survival if we can do that. Now again, there's a big case selection bias here because we tend to be picking out patients who've got solitary tumours, who are more biologically favourable, who haven't got that diffuse pattern of disease. So are we really making them live longer? Because we've heard already that most of them will die of recurrence again within the liver. Or maybe one of the things we should be thinking about is saying it's not just enough to remove what you can see and what's there on the scans, but we should then be thinking of adding in treatment to these patients on the grounds that they almost certainly must have something microscopically left within the liver that's going to reactivate within the next 2, 3, 4 years. Let's see if this one runs. This is a patient with an ocular melanoma metastasis in segment 8 of the liver. This is a smaller wedge resection. Segment 8 is the bit at the top on the right. And the pale dot on the top there is the only bit of the tumour that you can see. I'm using a laparoscopic ultrasound probe there, which enables me to identify the tumour, see the margins. We dissect through. The aim is not to see the tumour at any point other than on the scan, and to control all the blood vessels and work our way through the liver tissue, safely identifying, clipping all the vessels. I apologise for the slightly rubbish quality on this, but I did try and run it with a better quality, but it wouldn't run on PowerPoint. But you get the idea, don't you? I chop stuff out. It's death by 1,000 cuts on this particular occasion. I should have shown a slicker video, but this one is melanoma, so I had to show it. Okay. So at the end of the day, we're left with a crater in the liver, a lump. We check it again with the ultrasound to make sure that I've got decent margins and I'm still happy with it all. Because if I wasn't happy, I'd go and take a bit more. That patient went home 2 days after surgery, and she's alive and kicking 2 years out. So multi-modality cytoreduction is something that I've got an interest in, probably more than most of my liver surgery colleagues around the UK or indeed the world. I'm interested in looking at timing multiple interventions sequentially to maximise reduction in tumour volume with lowest risk. So that's a combination of local treatments, regional treatments, and systemic therapies. Now, a bit of what I'm going to talk about is theoretical, really, because we don't have the answers for this. But this is perhaps a way that I would see some treatment for ocular melanoma going. You need a team approach if you're going to deal with ocular melanoma, and indeed with the majority of cancers, because they do metastasize, because they do go to different places. You need support. It's not just a one-surgeon game. And the patients are an important part of all of this. You need dedicated pathologists, you need radiologists, particularly interventional radiologists who can't just find the disease, but they can help you treat it too. And oncologists, you always tend to assume that if you've got cancer, you need to be managed by an oncologist, but an oncologist may lead your treatment. Certainly, I'm not going to come up with all the smart stuff that's already been come out with, but I think there is still a role for a surgeon in here for a small percentage of patients. So what do you need for multi-modality cytoreduction? You need to pick a tumour that is biologically favourable if possible. So one definition of that would be that it's slow growing. Well, they can be. It preferentially involves a single metastatic site. Well, ocular melanoma does do that. There are multiple effective local interventions that have been described. Well, we know that there are interventions, both surgical and radiological, that can be applied locally. And what about low toxicity systemic therapy? Well, we're hearing more about that now. We don't always think of these cancers as being managed in this way, multimodality treatment, but actually, to some extent, most of them are. Bowel cancers are managed by colorectal surgeons who remove the primaries. They sometimes have radiotherapy to shrink them beforehand. They then have chemotherapy. They may get secondaries and be managed with a combination of surgery, radiological ablation, further chemotherapy. That's actually multimodality cytoreduction. You are aiming for cure, but you're also aiming to prolong life in a lot of patients and prolong quality of life. Again, the same for these other variants of tumours that are out there. So let's look at ocular melanoma again. Does it meet any of these criteria for this kind of approach? Well, you've got liver-dominant disease in the metastases. There's often a long interval to development of secondary disease, so that tends to suggest that there is at least a phase of biologically slow growth which could be targeted. The secondaries are hypervascular, and they've got a rich blood supply. If you've got rich blood supply, then you're amenable to interventions that feed off that blood supply. So introducing radioactive particles into the bloodstream, blocking off the blood vessels with beads or particles soaked in chemo, and there's resection there as well. And then again, we're looking, as Christian's just been talking about, all these biological treatments. So where does ocular melanoma come back? You've heard enough about it coming in the liver. Liver only in 55%. That's quite a decent sized group. And then a great range of other sites. And time to development of metastases. Can we pick out a group that are high risk that we should be targeting and that we should be following up rather more closely, that we should be putting our extra effort into? The deeper your tumour, the more likely you are to develop recurrence. Now, that's just one element of it. Now, you do get secondaries outside the liver as well, as we've just looked at. And intriguingly, patients who have an extra-hepatic presentation of disease in most studies appear to actually live longer rather than by comparison to those who have liver-predominant disease. So I think that'll be something that's interesting to look at from a tumour biology point of view. There are options for lung secondaries. You can resect them, you can ablate them. Ablating them means putting in a probe and either heating them up or cooling them down. Bone mets work with cryoablation, which is cooling them down. Brain secondaries, stereotactic surgery or radiosurgery, that's putting scaffolding on your head to work out the exact anatomical landmarks, and then targeting radiotherapy or targeting surgery directly down onto the points that are identified in relation to the fixed scaffolding on your head. The scaffolding comes off immediately after the operation, so it's not a permanent feature. We do see occasional patients with isolated intra-abdominal metastases, secondaries, and they're worth resecting. This was one of my very first OM patients from about 5 years ago who presented with this as a secondary in her adrenal gland. When we actually operated on her, she had a little chain of nodal disease running up and down her para-aortic chain. So I actually took all of her para-aortics on block, which is basically stripped all the tissue from the back of her tummy on the right side. And she managed about 2 years out of that before she then got disease in her head. Early detection, I think, is key. Risk stratification. We need to be identifying patients at high risk and then targeting our follow-up on them. I think lots of you get liver function tests and ultrasound scans. To be honest, for no other tumour group do we find liver function tests of any use as a screening tool. By the time your liver function tests have gone wrong, it's either the day after New Year and you've had one too many shandies, or your disease is rampant. So liver function tests we find, in general terms, to not be very helpful. They're either raised because of a spurious reason or it's too late. Ultrasound also is not a very good tool. It's very, very operator dependent. If you've got a fantastic radiologist doing it, then yes, you can get amazing results. But the chances are it will be not the top consultant in the UK who does your scan, and there are more consistent methods that can be picked. So I'm not discounting ultrasound, but I'm saying that I think there's better ones. The ultrasound's got the advantage of it doesn't give you any harmful radiotherapy. It's easy to tolerate, it's quick, it's cheap. CT scans, contrast-enhanced MR, and Brian, I suspect, will talk about diffusion-weighted MR as well. PET scans, well, they're probably too expensive and too cumbersome to use as a screening tool. But I think if we find somebody who's got a problem, then as soon as you've got a problem, whether it's been picked up on ultrasound, CT or MR, you need to make sure that you've had a CT of your chest, abdomen, pelvis, you've had an MR of your liver, you've had a PET CT, and if it looks like you've got operable disease in the liver, and that's the only situation really, then you need a laparoscopy. This is an example of somebody who is picked up there at a nice stage about 3.5 months ago with an easily operable lesion that I could take out as a keyhole procedure. They're referred around amongst various people pretty much on a monthly basis, and this is the time that they reach me as a liver surgeon. And it's gone from being something that I can nip out to being something that's extremely difficult. It's probably turned out to be inoperable. And that's gone from June to the middle of September. So speed is vitally important. You need to pick these things up early. You want them to pick them up that size and smaller, do small operations, turn you around quickly, rather than have this happen and this happen and this happen. So we need risk stratification, which has got to be on tumour factors. So where your primary tumour was, I think front of the eye is worse than back of the eye. The depth of the tumour, the diameter of the tumour. For those patients who've got tissue, then information about grade, invasion, information about genetics of the tumour. We also have to look as well and be sensible about what we're offering. If you're at the end of your natural life, then there's probably not a great deal of point making you travel for a whole load of scans. But if you've got good fitness, whatever your age, it's physiology. It's not just how many miles there are on the clock, it's how well you've been serviced. Is that right? That sounds bad, doesn't it? Let's not even go into that. But basically, if you're fit, then we should be looking at screening you if you're in a risk group. Rapid escalation to treatment. So as soon as there's anything to suggest that you've got ongoing disease, you need full staging with CT, MR, PET, laparoscopy if appropriate. You need to be seen by a multidisciplinary team that have got an interest in ocular melanoma and treatment of metastatic ocular melanoma. And treatment then needs to be commenced within weeks, not months. And the treatment options, well, surgical resection is a tiny percentage that surgery is the right one for. Transarterial chemo, I think you're going to hear more about this. Ablation, you'll hear more about. Certex, you'll hear more about. Systemic chemotherapy with biological agents, and I don't think we've completely discounted the role for cytotoxics, but they're certainly still there in all the trials, aren't they, if they are appropriately randomized. Multi-modality treatment, well, I think if you've got large deposits, solitary deposits, unilobar disease, or isolated extra-hepatic deposits, then that's where surgery comes in. Anything that's left, if you find that you crop up or when you get in there, there's tiny volume liver disease on the opposite side, then I'd embolize it or consider Certex for it. Cherry picking is a term that we sometimes use to describe picking out isolated deposits of disease And melanoma is one of those diseases where cherry-picking deposits as they crop up can be appropriate, whether they're cherry-picked by ablation or cherry-picked by surgery and systemic therapy. We haven't really defined how all of this fits in together, but I think these are things that we need to be thinking about. So if we're going to be offering some of these treatments, then you need to have a follow-up centre, really. It's got to have that interested multidisciplinary team. It's got to be high volume. It's got to have full screening and surveillance available. It's got to have advanced liver surgical expertise, advanced interventional radiology expertise. Ideally, it should have thoracic surgery and thoracic interventional radiology available as well, and neurosurgery. So, I mean, Liverpool ticks all those boxes. Yeah, the specialist oncology service. How do you get there? Well, I think the problem is, at the moment, most patients with ocular melanoma do get some follow-up, but they don't really get follow-up that is really designed to identify metastases early. Outside of the Liverpool study with MR, I think that's really been the only follow-up program that there has been in the UK that you could say really had a high chance of picking things up early. But when there's a gap in service provision, it's got to be paid for somehow. You've got to identify centres that are going to do the work. You've got to make sure you've got protocols that enable risk stratification so that we're not putting 600 people through investigations and tests that they don't need with all the attendant fear, worry, concern. We've got to pick out the people who are at highest risk, for whom the resource is best spent and for whom they've got the most to gain. Research has been mentioned many times already. One of the advantages of taking out big lumps is that you can send lots off to a tumour bank, which is what we do for most of our specimens. And recently Christian sorted out for us to have all the ethics approval to bank specimens for melanoma cases now as well. Then you can look at research into cell biology, genetics, immunotherapies, etc. I'm not smart enough to talk anything more about that. When you're looking at high volume centres, then you can also run trials and you can look at the international collaboration, and I think these are really key things. Trial design, well, I'm not going to come up with any trial design. That's again not one of my fortes, but you know, these are the sort of things that perhaps a step beyond what anybody's describing at the moment. We're talking all about systemic therapies at the moment in trials, but really we should also be thinking of combinations. We should be looking at a first hit and a second hit. So should we be looking at surgery and embolization followed by an immunotherapy? Or should we be looking at Certex followed by immunotherapy? These are the kind of combinations, and you can only look at trials like this if you've got large centres, international collaboration, etc. So I think there is hope for secondary ocular melanoma, but you need early detection, which needs a surveillance program that we haven't got. You need a coordinated strategy with people managed in high volume centres, which again largely doesn't happen. You need early multimodal intervention, and it needs trials to prove it works, or see if it does work. You need research. Now, there's a little bit of movement on all these things, but resource is required, I think. Thank you very much. Yeah.
On average, how long is it since detection before you actually get into surgery? And are you noticing a significant number of people that present with additional disease at that point that isn't seen on imaging?
Okay, so the question is, on average, how long is it until the patient presents for surgery and are we finding extra disease? Well, I think one of the things is that because there is no surveillance program, the patients that are coming through to us are largely self-referred. They found us off the internet, they found us by chance, and so some of those patients are managed via email and via seeing their discs, and they never come and see me because it's apparent that their disease is at a different stage, and they are put in touch with an oncology service local to them. So I think it's a really hard question to answer, but how often do I have a patient who has an ocular melanoma metastasis who's referred direct to me within at the point of first contact with a clinician who's identified that they have secondary disease? Never, except for local ones from Christian. Okay, yeah, thank you.
I'm a year out from having had my eye removed with a very
Yeah.
large tumour.
Yeah.
And I'm due to try and sort out, well, basically I've been advised ultrasound.
Yeah.
I've been told now that's not going to pick anything up if anything has started.
Yeah, I mean, ultrasound can pick things up, and ultrasound isn't rubbish, but if you're looking to pick up early disease, which is what you want because it's easier to treat and your immune system isn't so compromised, then you need something that is going to be more specific. And I think when Brian's given his talk, I would imagine he's going to cover some of these things, but usually it's either CT or diffusion-weighted MR or enhanced MR. So ultrasound isn't rubbish, but it's better than nothing. But it's equally, I don't think anyone would describe it as gold standard.
Granted, so how do I get to go to the gold standard?
Well, I think one of the long-term outcomes that we'd like to see from the development of this forum is agreement to developing protocols for follow-up so that we can then issue guidelines for surveillance that are agreed as a cross-specialty thing. And then so I'm not going to totally prejudge what those discussions might lead to. But that's really what we want. We want risk stratification. We want people with big tumours to be offered frequent scanning with the modalities that are most likely to identify disease early. And for you as an individual, if you haven't got that now and you can't wait, which I understand, then you need to see if your GP will refer you to a clinician who will offer that. Okay. Oh, next.
Graham White, plastic surgeon
Hi there.
from London. Like your talk very much.
Thank you.
I would caution a little bit giving patients advice that, not that it's rubbish, you didn't say that, but ultrasound is not as good as CT or MRI for follow-up. But
Yeah.
personally, I use CT for cutaneous melanomas.
Yeah.
Some patients were fortunate enough to have that facility. But as you said, it depends whose hands, who's doing the ultrasound.
Oh, yeah.
And if all the patients here go back to their treatment centres and say that they don't think ultrasound is good enough, and they're going to be demanding 6-monthly MRIs or CTs, which is going to give them a very high dose of radiation over a 10-year period, it'll be very expensive. And in those centres, it may not be what they actually want. Patients coming and saying, actually, we think ultrasound is not the best.
I'm sure it won't be what the centres want, but we don't use ultrasound for surveillance of any other liver malignancy or screening. We use CT or MR. So, I think that debate in terms of in liver surgical circles, ultrasound versus CT or MR is over.
I think the key issue is about the evidence. Now, if you can show that modality A is better or not than modality B, and if it has an impact on outcomes, survival, resectability,
Yeah.
and long-term quality of life, then you've got a case to make.
Yeah.
If it turns out that diffusion-weighted MRI is the way to go, well, then that's what needs to happen.
Yeah.
If it turns out that actually it doesn't make a difference, then we know the answer, and then there's no point.
Yeah.
And I think this is all about the trying to gather sufficient information so that we can make rational decisions about what we tell our patients and how we manage them. Don't you think?
Oh,
Because they're clearly lesions in the liver that you can't see on ultrasound that are very different. And you're not going to pick them up. There's no chance because you can't see them. Particularly close to the heart and up against the diaphragm. And there's no, even the radiologists who are experts will tell you that that's not a sensible tool for that part of the liver. And we go around this question when we see someone, not just with ocular melanoma, of course, but with abnormal liver imaging found on CT scan. When you go next door, first you do an ultrasound, and you still can't answer the question, you do your MRI scan, then do a PET scan, and then so it's not as very. I agree, it's not very straightforward, but you just need to generate the evidence so that you can resolve the question. And I
Yeah, no, I mean, I agree with what both of you are saying in some ways, in that at the end of the day, we have to stratify the population, we have to find those who are at highest risk, and we still have not positively identified with an evidence base which is the best tool for them. However, extrapolating from other liver disease, you'd say that ultrasound is not the best way. Yeah, Leslie.
I'd just like to add that many patients actually are not followed up by a regional centre. They will just be going to a district general hospital and they will be having local ultrasound and they will be told things like, oh, you've survived 5 years, you no longer need screening. And that's the problem. We're diffuse across the country.
Well, I mean, there's lots of precedent in this, isn't it? I mean, if you think about other rare conditions, childhood malignancies, sarcomas, gastrointestinal stenomas, where there isn't very much of it around, they're all sent to specialist centres. So surely for the rare tumours such as this, that's the way to go. And you know, no one would these days dream of managing a skin lymphoma in a local district hospital, because they would all go to someone who sees not one a year, but maybe 30 a year, and who will be part of driving the agenda for the patient. So I think that's what we need to achieve, and I do feel quite passionately about that.
Okay, thank you.
Thank you very much.